So I just will very quickly touch on some of the outcomes. What kind of data can you tell a patient when you stand in their bedside asking them, hey, do you want to do this surgery? I wrote this review paper because, this is in the Journal of Vascular Surgery, which is one of, our big journal, the Vascular Surgery's big journal. Because there was really nothing in our journal. There's a little bit in interventional cardiology, interventional radiology, but not much. And there certainly was really no review out there. What was being published is, series of 5, series of 10, in different institutions by different people. And this particular technique is challenging to learn and does have a little bit of art to it, as I mentioned, about going and coiling off the vessels. When do you take them for their angios? When do you do the amp? So there's a lot of heterogeneous approach to this. So just, getting the series of 6 patients out of, institution X doesn't really help anybody, because institution Y across the country is not going to be able to incorporate anything from that into their practice. So I wanted to do this review article so that it can really be out there what's going on right now, in 2020 across the world, in terms of open percutaneous and hybrid deep venous procedures. So what we did is a big database review, spent a lot of time getting out the number of patients that had deep venous arterialization. This was our exclusion criteria, and ultimately ended up with 18 studies, of which more than, significant majority were open deep venous arterialization, because that's really where it all started. And this is what most people are comfortable doing, especially because the surgeons, are comfortable doing surgery. And, when I'm doing a procedure, I know I can visualize and do an anastomosis with vein to the popliteal, to the PT. You start giving me, catheter wire, hey, fire this needle across, I might screw it up, not because I don't know conceptually what to do, but because, technically there's an issue. And so you want to start out doing stuff that you know. And that's why across the world, really, the open procedure was the mainstay of deep venous arterialization. As you can see, this goes all the way from 1984, and this is a guy who did one of the techniques, all the way to most recently, this one was 2017. And again, this is a paper from 2020. So, not much is being published. This is the number of patients per study. Okay. Again, not a lot, but decent numbers. I mean, 30 is pretty decent. The graft that was used to do the bypass, whether it was greater saphenous vein or if it's prosthetic, most people use greater saphenous vein. And then what was the target vein? Okay. And in almost all of these patients, they're shooting for a deep vein, the PT vein. And then what was the follow-up of these patients, right? So looking at this particular set of patients, this is here now with kind of the most important slide, limb salvage rates. Again, if you look here, small amounts of patients over a lot of time, but this was the limb salvage rate. I mean, in some of them, they're telling you 100%, in some of them, they're telling you 30%. The thing is, again, we don't know quantifiably what was the initial wound like, what was the original angio like. There's a lot of questions like, so how true is this data? But there's got to be some truth to it, so it's not zero. And again, all of these patients would have been 0% if not for the deep venous arterialization. Okay, obviously this is the wound healing, and this is the major amputation rate. Here they talk a little bit about anticoagulation. That's another story completely, depending on what type of procedure you do. I do anticoagulate all of these patients to give them the best chance of getting flow and not shutting down their bypass. This is what's out there for percutaneous. So look at that, going from just, like 10, 15 studies to just 3 studies, only 3 studies, all done fairly recently though. So unlike the open ones, which were, 2017, these were 2018, 2019. But again, look at that, 5 patients, 7 patients, 10 patients. So the answer is we really don't have great data, but the PROMISE trial is going to be an excellent, that's a randomized controlled trial that's funded and multi-center. So that's really going to give us some great data. And it's also going to control for the types of patients included, what their angiograms were, and then who the operators are. So I think that when that trial is completed, we're going to have a much better sense of how to do this procedure and who's good for the procedure. And since we're not doing that for the open procedures, I'll bet you that endo is really what takes off. So it's worth learning this. The wound healing rates here, again, you can see, small amounts of patients, 10 patients, 100%. Okay, sure. 5 patients, 40%. Okay. But again, major amputation, nobody got amputated in this group. And again, it was meant to be that everybody would have been amputated if not for the procedure. And then finally, this is the hybrid technique. 2018 and 2011, Dr. Ferrarisi wrote a paper, and this person wrote a paper. These had pretty decent amounts of patients. He used PTFE for this group, which is kind of fallen to the wayside. We wouldn't do PTFE bypasses if you don't have to. I think the logic here was, I don't want to take vein in case I need to do deep venous arterialization on the other side, but that's really not the way to go. If you have vein, you should be using vein to keep your bypass open. And then the follow-up also pretty low, but again, they got okay numbers for limb salvage and wound healing. But again, this is just a total of like 40 patients, which is not much. So overall, open outcomes, you can tell your patients, the primary patency, as in keeping the bypass open, is decent, but the most important thing is your chance of salvaging the limb is 25% to 100% based on data. And you should be standing there saying, if you don't do this procedure, then it's 100% I'm going to have to amputate you, which is not a bad thing either. Some people need amputations. And if it's somebody who you can amputate and they can get back on their feet with a prosthetic, it's the wrong thing to do a deep venous arterialization, make their legs swell, torture them for 7 months with something that potentially might not work, and now they're debilitated. But if it's somebody that really wants to keep their leg, and you should use your clinician judgment, then yes, this is an option and should be offered to patients. The percutaneous outcomes, again, just to tell patients, you can tell them, there's only a couple studies out there, but 50% wound healing and salvage rate is what you can expect. And with the hybrid procedure, again, really 50% around is what you can tell patients for their limb salvage rate. So in conclusion, deep venous arterialization is very much an acceptable option for the no option patient. So a patient that you're going to amputate, it's an option. There are multiple ways you can do it: endo, open, and hybrid being probably the most common technique used across the world today. And outcomes are very variable, not just because the technique is great or not great, but also because the operators are different, and because like I had a situation, that the first deep venous arterialization I did went excellent. It was the one that was after the one that I said we made the mistake on. So the first one that actually, successful, went excellent. Patient was bleeding like crazy from their wound, and they were in a nursing home, and the nursing home got worried because the bleeding was so good, put a tourniquet around the patient and sent them to the hospital. Tourniquet knocked off the bypass, and that was the end of it. She got amputated. So like there's a lot of reasons why things might not work out. But really, you as the operator need to kind of know all of the steps, be in control, pick the right patient, and then know when to go back and do multiple procedures to try to get blood flow to go to the toes. But if all these bits and pieces are done, this is very much a valid procedure that can salvage limbs in patients that are otherwise unsalvageable. Thank you very much.